fluids and electrolytes, acids and bases. Total body water, often abbreviated as TBW, makes up approximately 60% of an adult's body weight. This water is divided into two major compartments: the intracellular fluid, which is the fluid inside cells, and the extracellular fluid, which surrounds the cells. Extracellular fluid can be further categorized into interstitial fluid, which is found between the cells, intravascular fluid, which is the fluid within blood vessels, and transcellular fluids, such as synovial fluid in joints, cerebrospinal fluid surrounding the brain and spinal cord, gastrointestinal fluids, pleural fluids around the lungs, peritoneal fluids in the abdominal cavity, and urine. In pediatric populations, total body water makes up between 75 to 80% of their body weight. Because of this high percentage, infants and young children are especially susceptible to significant changes in body fluids, which places them at greater risk for dehydration, particularly in newborns. As individuals age, the percentage of total body water decreases. This decline is associated with a loss of free fat and muscle mass, a progressive reduction in renal function, and a diminished thirst perception. Together, these factors make older adults more vulnerable to fluid imbalances. Water moves between the body's fluid compartments primarily through two forces. Hydrostatic pressure pushes water out of the capillaries, a process known as filtration. On the other hand, osmotic and oncotic pressures work to pull water back into the capillaries, a process called reabsorption. The delicate balance between these forces ensures the proper distribution of fluids throughout the body's tissues and organs. The movement of water between fluid compartments is primarily governed by Starling forces. Net filtration is defined as the balance between the forces that favor filtration and those that oppose it. Forces that favor filtration include capillary hydrostatic pressure, often equated with blood pressure, and interstitial oncotic pressure, which refers to the pulling of water into the interstitial spaces. On the other hand, forces that favor reabsorption include capillary oncotic pressure, where proteins pull water back into the capillaries, and interstitial hydrostatic pressure, which helps push water back into the vascular system. This diagram illustrates the movement of water between fluid compartments, governed by a balance of pressures. At the arterial end of a capillary, capillary hydrostatic pressure pushes water out of the bloodstream into the interstitial space, a process known as filtration. Simultaneously, interstitial oncotic pressure draws water outward. As blood flows toward the venous end, capillary oncotic pressure becomes stronger, pulling water back into the vessels through reabsorption, aided by interstitial hydrostatic pressure. Water also moves between the interstitial fluid and the cells, influenced by intracellular osmotic pressure. The lymphatic system plays a crucial role by collecting excess fluid and returning it to circulation. Edema refers to the accumulation of fluid within the interstitial spaces of the body. Several factors can lead to the development of edema. These include an increase in capillary hydrostatic pressure, a decrease in plasma oncotic pressure, an increase in capillary permeability, and obstruction of lymphatic channels, a condition known as lymphedema. Edema may be localized, affecting a specific area, or generalized, involving a more widespread distribution throughout the body. Pitting edema is a specific type where pressing on the swollen area leaves an indentation, reflecting the severity of fluid accumulation. This diagram outlines the major mechanisms that contribute to edema formation. Decreased synthesis or loss of plasma proteins, often due to conditions like cirrhosis, malnutrition, or nephrotic syndrome, leads to decreased capillary oncotic pressure, allowing fluid to accumulate in tissues. Increased capillary permeability, caused by burns or inflammation, results in the loss of plasma proteins into the interstitial space, further promoting edema. Elevated capillary hydrostatic pressure, seen with venous obstruction, salt and water retention, or heart failure, also drives fluid into the tissues. Additionally, lymphatic obstruction decreases the clearance of filtered proteins, leading to increased tissue oncotic pressure and worsening edema. Sodium is the primary cation found in the extracellular fluid. It plays a critical role in regulating osmotic forces, which directly control the movement and distribution of water within the body. Sodium is essential for processes such as nerve impulse conduction, maintaining acid-base balance, supporting cellular biochemical activities, and enabling membrane transport. Chloride, on the other hand, is the primary extracellular anion. Its main role is to provide electroneutrality by balancing the positive charges of cations like sodium, thus contributing to the stability of the body's fluid and electrolyte environment. The renin-angiotensin-aldosterone system plays a critical role in regulating sodium and water balance. Aldosterone, a hormone secreted by the adrenal cortex, promotes the reabsorption of sodium and water back into the bloodstream, while simultaneously facilitating the excretion of potassium. In contrast, natriuretic peptides act to lower blood volume by promoting the excretion of sodium and water, counterbalancing the effects of aldosterone. Together, these hormonal systems maintain the delicate balance of fluids and electrolytes within the body. Water balance in the body is tightly regulated through two key mechanisms. First, the secretion of antidiuretic hormone, or AD, increases water reabsorption into the plasma, helping to conserve body water and maintain blood pressure. Second, thirst perception is triggered by specialized receptors. Osmoreceptors detect changes in the concentration of solutes in the blood. Volume receptors monitor the stretch of blood vessels, and baroreceptors sense changes in blood pressure. Together, these mechanisms ensure that the body maintains proper hydration and circulatory stability. This diagram illustrates how the antidiuretic hormone system maintains water balance. An increase in plasma osmolality is detected by brain osmoreceptors, while a decrease in plasma volume is detected by volume receptors. These signals stimulate the hypothalamus, which then activates the pars nervosa of the posterior pituitary to release antidiuretic hormone, or ADH. ADH acts on the kidneys to promote renal water retention. As a result, plasma osmolality decreases and plasma volume increases, restoring homeostasis. Additionally, the hypothalamus drives thirst and fluid intake to further support fluid balance. Isotonic alterations occur when there is a change in total body water that is matched by a proportional change in electrolytes, meaning there is no shift in concentration. When the body loses isotonic fluid, a condition called hypovolemia develops, leading to a decrease in circulating blood volume. Conversely, isotonic fluid excess results in hypervolemia, where an increased volume of circulating fluid can strain the cardiovascular system. Hypertonic alterations are characterized by an increase in plasma osmolality. This condition often leads to hypernatremia, where there is an elevated concentration of sodium in the extracellular fluid. A key feature of hypertonic alterations is a water deficit in the extracellular fluid, resulting in dehydration. The imbalance pulls water out of the cells, causing them to shrink and impairing cellular function. Hypernatremia occurs when serum sodium levels exceed 145 milliequivalents per liter. This condition can result from either an excess of sodium or a loss of water from the body. The major manifestations of hypernatremia include brain cell shrinkage, which can lead to neurological symptoms, altered membrane potentials that disrupt normal nerve and muscle function, and an increase in blood pressure due to changes in vascular tone and fluid balance. Hypernatremia can be classified into three types based on the body's fluid status. In isovolemic hypernatremia, there is a deficit of free water while sodium levels remain relatively normal. Hypovolemic hypernatremia results from a loss of both sodium and water, with a greater loss of water than sodium. In contrast, hypervolemic hypernatremia occurs when there is an increase in both body water and sodium, but the sodium increase is proportionally greater. Additionally, hyperchloremia, an elevated chloride level, often accompanies hypernatremia and further impacts fluid and electrolyte balance. Hypotonic alterations are characterized by a decrease in plasma osmolality. This condition typically results in hyponatremia, where the concentration of sodium in the extracellular fluid falls below normal levels. As water shifts into the extracellular space, excess water dilutes the sodium concentration, disrupting normal cellular and physiological functions. Hyponatremia is defined as a serum sodium level less than 135 milliequivalents per liter. It typically results from either a loss of sodium or a gain of water. The manifestations of hyponatremia include cellular swelling due to water shifting into cells, altered action potentials affecting nerve and muscle function, cerebral edema, and increased intracranial pressure, all of which can have serious neurological consequences. Hyponatremia can be categorized based on the body's fluid volume status. In isovolemic hyponatremia, there is a loss of sodium with a relatively normal amount of body water. Hypervolemic hyponatremia occurs when an increase in body sodium leads to an even greater increase in body water. Hypovolemic hyponatremia results from the loss of both sodium and water, with a greater loss of sodium. Dilutional hyponatremia arises when large amounts of free water are consumed, diluting the sodium concentration. Additionally, hypochloremia, or low chloride levels, often accompanies hyponatremia, further affecting fluid and electrolyte balance. Potassium is the major intracellular cation in the body, playing a vital role in maintaining cellular function. Its concentration inside cells is carefully regulated by the sodium-potassium ATPase pump. Potassium helps regulate intracellular electrical neutrality, balancing the positive charges of sodium and hydrogen ions. It also supports critical physiological processes such as glycogen and glucose deposition, maintaining normal cardiac rhythms, and enabling the contraction of both skeletal and smooth muscle. Potassium balance is closely influenced by changes in pH. During states of acidosis, hydrogen ions accumulate within cells, causing potassium ions to shift out into the extracellular fluid to maintain electrical neutrality. This shift can result in hyperkalemia. Hormones such as aldosterone, insulin, and epinephrine also play important roles in regulating serum potassium levels. The kidneys are the body's most efficient regulators of potassium, ensuring its proper balance. When potassium levels change slowly over time, the body can better adapt. However, acute changes are more difficult to tolerate and may lead to serious complications. Hypokalemia is defined as a potassium level of less than 3.5 milliequivalents per liter. Potassium balance in the body is primarily assessed through changes in plasma potassium levels. Common causes of hypokalemia include a reduced intake of potassium, an increased movement of potassium into cells, and increased losses of potassium from the body, either through the kidneys, gastrointestinal tract, or skin. The manifestations of hypokalemia depend on both the rate at which potassium levels fall and the severity of the deficit. One of the key physiological effects is membrane hyperpolarization, which decreases neuromuscular excitability. This results in skeletal muscle weakness, smooth muscle atony, and potentially dangerous cardiac dysrhythmias. Hypokalemia can also impair glucose metabolism, leading to glucose intolerance, and it may reduce the kidney's ability to concentrate urine, contributing to fluid imbalance. Hyperkalemia is defined as a serum potassium level greater than 5.5 milliequivalents per liter. Although it's relatively rare, this condition can still occur despite the kidney's highly efficient potassium excretion. Hyperkalemia may result from excessive potassium intake, a shift of potassium from the intracellular fluid into the extracellular fluid, decreased renal elimination, insulin deficiency, or direct cell trauma such as burns or injury. The clinical manifestations of hyperkalemia depend on the severity of potassium elevation. In mild cases, patients may experience increased neuromuscular irritability, presenting as restlessness, intestinal cramping, and diarrhea. As potassium levels continue to rise, severe attacks may occur. These involve a decrease in the resting membrane potential, leading to muscle weakness, reduced muscle tone, and even paralysis. These symptoms can be life-threatening if not promptly managed. Potassium imbalances significantly affect cardiac electrical activity, and these changes are reflected in the electrocardiogram, or ECG. In normokalemia, or normal potassium levels, the ECG shows a standard PR interval, a normal QRS complex, and a rounded, appropriately sized T wave. With hypokalemia, you may see a slightly prolonged PR interval, a slightly peaked P wave, shallow T waves, ST segment depression, and the appearance of a prominent U wave. In hyperkalemia, the ECG often reveals a tall, peaked T wave, a wide and flat P wave, a prolonged PR interval, a widened QRS complex, and a depressed ST segment. These electrical alterations can be early signs of serious cardiac risk. 99% of the body's calcium is stored in bones, primarily in the form of hydroxyapatite. Calcium is essential for a wide range of physiological functions. It supports metabolic processes, builds the structure of bones and teeth, enables blood clotting, regulates hormone secretion, maintains plasma membrane stability, and facilitates the transmission of nerve impulses and muscle contractions. The hormones parathyroid hormone, vitamin D3, and calcitonin work in coordination to regulate calcium levels by controlling phosphate absorption and excretion. The normal range for calcium in the blood is 8.8 to 10.5 milligrams per deciliter. Hypokalemia refers to a decreased concentration of calcium in the blood. It can result from a number of causes, including inadequate intestinal absorption, deposition of ionized calcium into bone or soft tissue, administration of blood products, and deficiencies in parathyroid hormone or vitamin D. Poor nutritional intake of calcium may also contribute. The physiological effects of hypokalemia include increased neuromuscular excitability, which can lead to symptoms such as muscle spasms, tetany, and convulsions in severe cases. On an electrocardiogram, hypokalemia may present with a prolonged QT interval and, in critical situations, can progress to cardiac arrest. Hyperkalemia refers to an elevated concentration of calcium in the blood. It can be caused by several conditions, including hyperparathyroidism, bone metastases, sarcoidosis, excessive intake of vitamin D, and tumors that produce parathyroid hormone. The effects of hyperkalemia are often nonspecific and may include fatigue, weakness, lethargy, anorexia, nausea, and constipation. More serious consequences involve impaired renal function, kidney stone formation, cardiac dysrhythmias, bone pain, and osteoporosis. If left untreated, hyperkalemia can significantly impact both organ function and quality of life. Like calcium, most of the body's phosphate is stored in the bones. Phosphate plays a crucial role in cellular metabolism and provides energy for muscle contraction. It is closely regulated by parathyroid hormone, vitamin D3, and calcitonin, which work together to control its absorption and excretion. The normal serum phosphate range is between 2.5 and 5.0 milligrams per deciliter. Hypophosphatemia refers to a decreased concentration of phosphate in the blood. It can result from intestinal malabsorption, respiratory alkalosis, or hyperparathyroidism. The effects of hypophosphatemia are widespread, including impaired oxygen transport by red blood cells and disrupted energy metabolism, leading to deranged nerve and muscle function. Severe cases may present with irritability, confusion, numbness, coma, and convulsions. Additionally, patients may develop respiratory failure, cardiomyopathies, and increased bone resorption. Hyperphosphatemia refers to an elevated concentration of phosphate in the blood, often accompanied by a decrease in serum calcium levels. Common causes include renal failure, chemotherapy treatments, prolonged use of laxatives or enemas, and hypoparathyroidism. The effects of hyperphosphatemia are primarily linked to symptoms of low calcium, and in prolonged cases, excess phosphate can lead to the calcification of soft tissues, which may impair the function of vital organs. Magnesium is an important intracellular cation that acts as a cofactor in numerous intracellular enzymatic reactions. It plays a vital role in regulating neuromuscular excitability, helping to maintain proper nerve and muscle function. The normal magnesium concentration in the blood ranges from 1.8 to 3.0 milliequivalents per liter. Hypomagnesemia refers to a decreased concentration of magnesium in the blood. It can be caused by malnutrition, malabsorption syndromes, chronic alcoholism, and excessive urinary losses. The effects of hypomagnesemia include behavioral changes such as irritability, along with neuromuscular symptoms like increased reflexes, muscle cramps, ataxia, nystagmus, tetany, and convulsions. Cardiovascular manifestations can also occur, including tachycardia and hypotension. Hypermagnesemia is defined as an increased concentration of magnesium in the blood. It often results from renal insufficiency or failure, excessive intake of magnesium-containing antacids, or adrenal insufficiency. The effects of hypermagnesemia include skeletal and smooth muscle contraction, a loss of deep tendon reflexes, and generalized muscle weakness. Additional symptoms can include nausea, vomiting, and signs of excess nerve function. In more severe cases, hypermagnesemia may lead to hypotension, bradycardia, and respiratory distress. Acid-base balance is tightly regulated by the body through multiple mechanisms to maintain a normal blood pH. Even small deviations from the normal pH range can significantly disrupt biological processes, affecting enzyme activity, cellular function, and overall homeostasis. pH is defined as the negative logarithm of the hydrogen ion concentration in a solution. In biologic fluids, a pH of 7.4 is considered neutral. When hydrogen ion concentrations are high, the pH falls and the fluid becomes acidic. Conversely, when hydrogen ion concentrations are low, the pH rises and the fluid becomes alkaline. Acids are formed as end products of the metabolism of proteins, carbohydrates, and fats. Acids are substances that donate hydrogen ions, or H+. To maintain the body's normal pH, these acids must be balanced by bases, which are substances that accept hydrogen ions. The bones, lungs, and kidneys work together as the major organs responsible for regulating acid-base balance, helping to keep the internal environment stable despite continuous metabolic activity. Body acids exist in two main forms: volatile, and non-volatile. Volatile acids, such as carbonic acid, can be eliminated from the body as carbon dioxide gas through the lungs. In contrast, non-volatile acids, including lactic acid, sulfuric acid, phosphoric acid, and other organic acids, cannot be expelled by the lungs and must be eliminated by the kidneys. Proper regulation of both types is essential for maintaining a stable pH in the body. The body maintains normal pH through three primary mechanisms. First, physiologic or chemical buffer systems act immediately to neutralize excess acids or bases. Second, respiratory acid-base control regulates pH by adjusting the amount of carbon dioxide exhaled by the lungs. Third, renal acid-base control fine-tunes pH over a longer period by excreting hydrogen ions and reabsorbing bicarbonate in the kidneys. Together, these systems work continuously to stabilize the body's internal environment. A buffer is a chemical substance that can bind to excessive hydrogen ions or hydroxide ions, preventing significant changes in pH. The body's primary buffer systems include the bicarbonate carbonic acid buffering system, protein buffering, and renal buffering. Each of these systems plays a critical role in quickly stabilizing pH when acids or bases threaten to disrupt the body's internal balance. The bicarbonate carbonic acid buffer system is the primary chemical buffer in the body. In this system, carbon dioxide combines with water to form carbonic acid. Carbonic acid then dissociates into a hydrogen ion, acting as an acid, and a bicarbonate ion, acting as a base. This reaction is reversible, allowing the system to dynamically help maintain pH balance. It operates across two organs. The lungs regulate the amount of carbon dioxide exhaled, while the kidneys reabsorb or regenerate bicarbonate and excrete hydrogen ions into the urine. Protein buffering is an important mechanism for maintaining pH balance. Proteins have negative charges, allowing them to bind to hydrogen ions and act as effective buffers. Hemoglobin, found in red blood cells, serves as one of the body's most powerful protein buffers. Renal buffering also plays a critical role. In the kidneys, the phosphate buffer system and the ammonia buffer system actively regulate pH within the renal tubules, helping to eliminate excess hydrogen ions and maintain acid-base homeostasis. Changes in hydrogen ion concentration are the primary cause of acid-base imbalances. Acidosis occurs when there is a systemic increase in hydrogen ions or a decrease in bicarbonate, leading to a lower blood pH. In contrast, alkalosis develops when there is a systemic decrease in hydrogen ions or an increase in bicarbonate, resulting in a higher blood pH. Both conditions can severely disrupt normal cellular and organ function if not corrected. This diagram shows how small changes in blood pH can lead to significant consequences. Normal blood pH ranges tightly between 7.35 and 7.45. A pH below 7.35 indicates acidosis, and if it drops further towards 6.8, it becomes life-threatening. On the other side, a pH above 7.45 signifies alkalosis, and values approaching 7.8 can also be fatal. Maintaining the correct ratio between carbonic acid and bicarbonate through respiratory and renal regulation is critical for keeping the blood pH within this narrow and essential range. When acid-base imbalances occur, the body initiates compensation mechanisms to restore balance. Renal compensation involves the kidneys reabsorbing bicarbonate into the plasma and excreting hydrogen ions into the urine, helping to correct pH over hours to days. Respiratory compensation acts more quickly. The lungs respond by breathing deeply and rapidly to eliminate excess carbon dioxide, which reduces acidity and helps stabilize blood. Metabolic acidosis occurs when there is a decrease in blood pH, often accompanied by a normal or low partial pressure of carbon dioxide. A common example of metabolic acidosis is diabetic ketoacidosis, where excessive acid production overwhelms the body's buffering systems. On the other hand, metabolic alkalosis is characterized by an elevated blood pH and an increased bicarbonate level. This condition typically results from an excessive loss of metabolic acids, such as through prolonged vomiting or diuretic use. Respiratory acidosis is characterized by a low blood pH and an elevated partial pressure of carbon dioxide. It results from alveolar hypoventilation, where the lungs fail to expel enough carbon dioxide, leading to acid accumulation. In contrast, respiratory alkalosis presents with a high blood pH and a low partial pressure of carbon dioxide. It is caused by alveolar hyperventilation, where excessive breathing expels too much carbon dioxide, creating an alkaline state